Respected judges and my dear friends, good afternoon. Today I'm going to speak to you about electron microscopy analysis in non-penetrating deep sclerectomy surgery. There are no financial interests. Academic disclosures. This paper was written with the guidance of Professor Harminder Dua. Dua et al. Have said that the collagen matrix of the human trabecular meshwork is a direct extension of the novel pre-Descemet's layer. This was the landmark paper of 2014, which was the basis of our study. These are the photos from their paper where they describe the Dua's layer as a distinct layer from the Descemet's membrane. And these are the pictures where it continues as the trabecular meshwork. Deep sclerectomy is a surgery where in non-penetrating glaucoma surgery in which there is deep dissection in the region of the limbus and cornea, which facilitates aqueous outflow. It has its advantages of low risk of endophthalmitis, hypotonic maculopathy, and choroidal effusion. However, there is no way of predicting which cases succeed. Some authors have suggested that the inner wall of the Schlemm's canal and the outer layer of the trabecular meshwork has to be removed, while some have suggested that the biomechanics of the cornea are altered after deep sclerectomy. Both these properties are present in the Dua's layer. First of all, it is impervious, and secondly, it is stiff and has provides good biomechanics to the cornea. But removal of this layer will obviously improve the perviousness as well as reduce the biomechanics of the cornea. So we hypothesize that if this layer is selectively removed, then the aqueous drainage may improve and the IOP will reduce. So we perform non-penetrating glaucoma surgery on 40 eyes of 20 patients. Triple-blind random comparative case control video audit, OCT, and electron microscopy was performed. The deep flap removed from 3 failed cases and 3 successful cases were examined under the electron microscope, scanning electron microscope, and the EM was reviewed by 2 pathologists, 2 eye surgeons, and the investigator and the statistician were also blinded. We also performed clinical OCT and video audit. On clinical, we qualified success at 12% reduction of IOP without drops. In video audit, we look for the egress of the dye from the thin membrane, and on AIOC we look for a thin membrane with a continuous bleb. The results were that we divided into 2 groups. The successful groups were 30 out of the 40 cases, and 10 were failures. These were reviewed by 2 independent surgeons based on IOP, clinical bleb, OCT bleb, video audit, and they are further classified into Group A EM and Group B EM. The Group A EM had 3 cases which were successful, and Group B EM had 3 cases which were failed. And both these cases, all the 3 cases from the 2 groups were matched for age, type of glaucoma, stage of glaucoma, and tissue collected at EM. So these are the descriptive statistics that I have just spoken about. And these are the surgical statistics in terms of the time of surgery taken and no intraoperative complications. The results suggest that the successful cases showed a mean reduction of 21%, while the failed cases showed a mean reduction of 7% in the IOP. The 3 successful eyes from whom the 3 eyes who qualified as success of deep sclerectomy were selected, and the tissue was sent for electron microscopy, and we found that Dua's layer was identified in all the 3 cases. While the corresponding failed surgeries, we could not identify Dua's layer from the deep flap that was removed during surgery. So this is a video of the surgery which shows फोल्डर में देखो, अरे फोल्डर है ना इसका, एक So the superficial flap being removed first, followed by the deeper dissection. We go right up to the outer cornea, and then we go deeper down, right up to the Descemet's membrane. We remove the pre-Descemet's layer, as can be seen in this surgery. After that, we can see the fluid, aqueous fluid coming out, which is then confirmed by injecting. This is the last layer being removed. That's the pre-Descemet's layer. That one is sent for electron microscopy, and we inject the dye and look for the egress of the dye from the thin flap. So These are the EM of the successful cases, and these are the EMs of the failed cases. The successful cases show Dua's layer, and this picture was confirmed with Professor Dua. And these are the failed cases which show deep stromal fibers. OCT also shows a thin membrane, that's the Descemet's membrane, and the bleb. And the raster OCT confirms the same findings where we see the membrane as well as the bleb. Why should we remove the Dua's layers? Well, it is an impervious layer which can withstand pressures up to 200 kPa. Where we have the residual Descemet's and Dua's layer present, these are the cases which fail, and they are seen as thick membrane on OCT, and on EM we don't see the Dua's layer. While in the cases where we see a thin layer on OCT, we find that these cases are successful and they are confirmed on electron microscopy. So we postulate that the thick membrane that withstands pressure and does not allow egress of fluid is a sclerosed peripheral part of Dua's layer, which if not removed leads to failure of deep sclerectomy, and removal of this layer is key to success of deep sclerectomy. In conclusion, it is removal of Dua's layer is vital for success. Video audit, OCT and EM findings suggest the same, and this study gives an objective perspective to the surgical success of deep sclerectomy surgery, and lamellar coronary surgery may be a part of further glaucoma training programs. Thank you.